Hello everybody, this is Dr. Nadeem and we are with Neelam Path Lectures, the Pursue series. As you're aware, all our lectures are available on YouTube. We also have a Telegram group which is very helpful for accessing all lecture related information. You can join that group. We have a Google Drive where all the PDF of lectures are available. You can join the group as well as access the Google Drive. These are the disclaimers. And we are with phase 3, which is recorded pathology lectures. And today we have Pursue 3J, which is soft tissue and bone tumors, and we are streaming from Kolkata. And today's topic is approach to primary bone tumors in small biopsies. And to talk on that, we have Dr. Bhaskar Mitra, who is an MBBS from Calcutta, MD and DNB in pathology, a gold medalist. He's a consultant histopathologist at the very famous Drs. Tribedi and Roy Diagnostic Laboratories, Kolkata. He's got multiple publications in indexed national and international journals. So without much delay, I would request Dr. Bhaskar Mitra to start his lecture on approach to bone tumors in small biopsies. Over to you, Dr. Mitra. Thank you.
Good morning, everybody. I am Dr. Bhaskar Mitra. Today, I am giving my second lecture, the discussion about the approach to primary bone tumor. Now, today, I am going to tell about the how algorithm-wise we can approach and solve the confusions regarding the bone tumors. And how will you approach when a bone tumor slide was present in your table for diagnosis? This is the main key diagnostic thing. If you try to look at the whole thing or the abnormality in the bone without a system, then you will get lost. Once you have a system that works and apply it every time, then the diagnosis becomes self-apparent, or at the very least a rational plan of attack develops towards the diagnosis. Now, with the plan, we need players. In the bone diagnosis or the treatment of the bones lesions, there are three players. First, the orthopedician or the surgeons. Next comes the radiologist, and then obviously the pathologist. They together we plan the comprehensive and accurate treatment for the bone lesion. First, on the clinical background, the radiologist give us the imaging finding. On the image, based on this imaging finding, orthopedician put the biopsies and we interpret the biopsy, and as per our diagnosis, the treatment of the patient has been decided. Now today's presentation first will focus on the understanding of a clinical algorithm to solve the bone lesions. Now to correlate how the clinical presentation and the radiological findings help in the approach to the diagnosis. To understand the classification of the bone lesions, particularly the bone tumors, correlate the histopathological findings with the clinical presentation, and after all, the team approach of the radiologist, the orthopedician, the clinical part, and the pathologist, the biopsy part, the integration of these all three. Now, before starting the bone pathology, first think of the three things. What is the age of the patient, and where is the abnormality, what type of tumor, and what is the nature of tumor. So first is the demographic details, the age, sex. Some diseases are particularly prevalent in the children, male or female preponderance in some of the cases. Whether the lesion is a single lesion or a multiple lesion. What is the location of the lesion in the skeleton? In which bone? Is it in the long bone or in the flat bones or in the individual bone, whether it is in the epiphysis, metaphysis or diaphysis region? Where comes the role of radiology in the determination of the location? Now, the radiological details like the border of the tumor, whether it is showing any bone destruction, any periosteal reaction. Then comes the matrix and other soft tissue mass formation in this bone tumor. So again, the key things are age of the patient, location of the tumor, radiological appearance and the histological features. Now, as I am saying, some of the diseases are prevalent in the children, some are in the older age group. Now, if we make a table and divide different age group like 0 to 10, 11 to 20, 20 to 40 and 40 and above, and divide the whole bone lesions into the benign and the malignant counterpart, then the situation would be like this. In the under 10 category, there will be the benign lesions like simple bone cyst, eosinophilic granuloma, Ewing sarcoma, leukemic involvement are more common on the malignant counterpart. 11 to 20, the adolescent group will suffer from non-ossifying fibroma, fibrous dysplasia, simple bone cyst, aneurysmal bone cyst, different osteogenic lesion like osteochondroma, osteoidostoma, osteoblastoma, chondrogenic lesion like chondroblastoma. In the malignant counterpart, there is osteosarcoma and the Ewing's tumor. In the 21 to 40 age group comes the giant cell tumor, that is more than, and the cartilaginous tumor. In the malignancy, there is a chondrosarcoma, the malignant counterpart of the cartilaginous tumor. 40 and above, for the benign, the diseases are much less. The osteoma, most of the diseases are the malignant, among which the most important and most common is the metastatic tumor, followed by myeloma, leukemic or lymphomatous involvement. Then comes the chondrosarcoma, osteosarcoma second peak, malignant fibrous histiocytoma, chordoma. These are the lesions are very common. This is a picture showing different type of lesion in a different locations in our skeleton, like eosinophilic granuloma, mates, myeloma, more common on the flat bones, particularly the skulls. Adamantinoma is common for the mandible. Humerus, all kind of bone cyst is very common. Ribs for metastasis and enchondromas. Spine for the metastasis is another important site. Pelvis is a very important site for the osteosarcoma, Ewing's. Distal end of radius, giant cell tumor is one of the important factor. So this is the how the site is important for the bone lesions. Now, some of the bone lesions can be divided again into the skeletal, as per skeletal distribution, like some are maybe in the peripheral or the long bones or the extremities are affected. Some affects the axial bones like the skull, spine, pelvis. This way we can divide the things into the different parts. But some of the lesions can be prevalent both in the axial as well as in the peripheral. Now comes the importance of epiphysis, diaphysis and metaphysis. We all know what are these: epiphysis, diaphysis and metaphysis. Diaphysis is the central part of the bone where the intermedullary lesions are very common like Ewing sarcoma, lymphoma, myeloma. Metaphyseal area is the growing end of the bone, so there lies the osteoidostoma. Mostly the malignant tumors like osteosarcoma, chondrosarcoma, fibrosarcoma, osteoblastoma is more prevalent on the metaphyseal part. Now for the epiphysis, there is a one monopoly for the chondroblastoma, that is another is for the giant cell tumor of bone. It is more common on the epiphyseal part. Now here comes the, if the radiologist says what is the epicenter of the lesion, is it in the diaphysis, then we will be thinking of these lesions. Whether it is in the metaphysis, think of this. If it is in the epiphysis, think of chondroblastoma, giant cell tumor, these things. So as per epiphyseal, metaphyseal and diaphyseal location, these are the most common tumor locations like chondroblastoma, giant cell tumor, as I said earlier, is it for the epiphyseal thing. Metaphysis comes the osteoblastoma, osteochondroma, non-ossifying giant cell tumor again, diaphysis for these lesions. So these are the different lesions occurring in the different facial region. So on this background, we have to go step by step. Then only we can reach the success. So we have to have a complete clinical and the age, sex, particular location, any significant history of the patient of any particular disease, that is very important for the bone lesions. I will be coming back details onto this. Now then comes the radiology, the X-ray, CT or MRI findings. This will be very helpful to differentiate the nature of the lesions and also shut down our differential diagnosis. So then comes the classification of the bone lesion. This is the long list of different type of bone lesion starting with different things. Here I will first like to highlight what are the categories. If you remember the categories of the bone lesion, then it would be very easier to go into the details. First is the hematopoietic. Is it the lesions affecting the bone arising from the blood hematological malignancies? Very important. Then comes the cartilage producing. So chondrogenic tumors, both benign and the malignant counterpart. Then comes the bone forming or the osteogenic lesion. There may be the histocytic origin of the tumor cells. There may be fibrogenic or the fibrous origin of the tumor cells. There may be prominent of the vascular network or the blood vessel component, vascular component on the tumor, which is very important if the different vascular lesion. Then comes the lipogenic and the neurogenic lesions. To understand this type of lesion, we have to again go into the embryology. So as in our first lecture, we have discussed different type of cells like osteoblast, osteoid forming cells, osteocyte, osteoblast, giant cells, from where they arises. So this is nothing but arising from the mesenchymal stem cells. Now mesenchymal stem cells give rise to the bone forming osteoblastic cells, cartilage forming chondrocytic cells. There may be myoblast or muscle forming cells which ultimately give rise to the striated muscles of the body. There may be stromal cells or the stromal fibroblasts giving rise to the fibroblastic lesions. There may be tendoblast which will give rise to the tendons, and the lipoblast ultimately giving rise to the adipocytes. So as per origin or as per histogenesis of the lesions, we divide it into the major groups. First is the osteoblastic, the bone forming one. Then comes the cartilage forming one or the chondrocytic lesion. Fibroblastic lesion, the stromal fibrous tissue forming lesions. There may be some telangiectatic lesions, that is very important. And apart from all these things, there may be the small cell lesions and the giant cell lesions. We will be discussing it soon. So as per category of the different histogenesis, we can divide the bones into the following group. First is the bone forming or osteogenic lesions. Then comes the osteofibrous lesion, where there may be development of a disorganized bone along with the fibrous tissue. There may be chondroid lesions. These are the chondrocytes. These are the typical characteristic findings of the chondrocyte that are present within a lacuna or the empty spaces. Then comes the blue round cell tumors or the small cell tumors of the bone, and there may be the telangiectatic or vascular lesions. Some tumors itself has high vascularity, giving an appearance of a telangiectatic lesion. Some are true telangiectatic lesions. So in the bone diagnosis, we see ABC like areas in many of the tumors, and ABC itself is a pathological lesion. So again, there is bone forming osteogenic tumors. There may be small round cell tumors, cartilage producing tumors, and definitely opposite of small cell, there is a giant cell tumor where we can see multiple numerous giant cells in the lesions. So first, when you get a slide, first decide these four things: whether you are seeing bones or bone forming lesions, or cartilage forming lesion. You are looking to a small cell lesion full of small cells, or we are looking at a fibrohistiocytic lesions or giant cell containing lesions. So first categorize your slide. It is from bone, it is from cartilage, it is from the giant cells, or it is from the small cell lesions. So when you see a slide which forms a lots of bone like this, there you can see very easily identify the bones. So this is a bone forming lesion or osteogenic lesion. It may be benign. Here the benignity of the lesions are indicated by first the cellularity, the cellular atypia, presence of mitosis and other bony destruction, lymphovascular invasion or the aggressiveness of the tumor. In between this benign and malignant, there is an important entity in cases of the orthopedic or bone pathology is the aggressive benign lesions. The aggressive lesions are actually the benign lesions, but they behave more aggressively, they spreads, they recur. So these are the aggressive lesions. So in the bone forming lesions on the benign counterpart, there are the osteomas where you can see the mature lamellar bone, the Haversian system, which I discussed very clearly in my first lecture. Then comes the malignant part. Here you can see anybody can say this is a malignant lesion considering the cellularity and the cellular atypia, small big cells along with lace like osteogenic material or osteoid forming. Here again small. As here you can see there is a transition in the benign part, there is a more of bones. In the malignant part, this is more of cell, less bone. And in between lies the osteoblastoma. This is an aggressive variant where we can see a mixture of both bone as well as the cellular counterpart. Now, we will approach these lesions in an algorithmic way. So first we have decided this is a osteoid forming tumor or osteoid bony lesion. Now, whether it is a benign and malignant, go for the clue in the radiology. Whether the radiologist said this has a benign nature, well circumscribed lesion, well delineated border, no bone destruction, no soft tissue mass, no moth-eaten appearance, this is like. Then you have to look for location again in the radiology, whether this lesion is a cortical radiolucency or a medullary radiogens lesion. If it is a cortical radiolucency with a nidus and affecting the lamellar bones, then it has to be an osteoma. Now then comes the nidus. What is nidus? Nidus is nothing but a core material containing of proliferated capillaries surrounded by bone formation. So there is the bone forming lesions with a central nidus, central capillary forming areas. Again, so this is an osteoid osteoma, again a benign lesion, nidus less than 1.5, the nidus may be larger, that is more than 1.5. This is a lesion showing too much cellularity with bone, giant cells, etc. This is an aggressive lesion, this is an osteoblastoma. This is again the aggressive osteoblastoma. This is the osteoblastoma with more aggressive form. We consider it aggressive osteoblastoma where we can see the epithelioid osteoblast in the lesions. So first, bone forming lesion, benign lesion by radiology, seeing nidus, it's osteoid osteoma. Without nidus, only lamellar mature bones, no cells, is osteoma. Then if the cell increases but cell do not showing any, here we see very clearly this is the osteoblastoma and osteoid osteoma. So benign to intermediate areas, there may be more importantly the osteoid trabeculae in the osteoblastoma are discontinuous and irregular bone formation is there, abundant fibrostomal tissue and multiple cells and multinucleated osteoblastic giant cells are there. Osteoid osteoma, the osteoid and the trabeculae are continuous and a regular bone. It is more like a mature bone. Scanty fibrostroma, it's a more of a bone, multinucleated cells and the cells are there. So in the osteoid osteoma, there is a less cellularity, less cells, more bone, but in the osteoblastoma, there is a more cellularity, less bone. Now, there is a difference between osteoblastoma and aggressive osteoblastoma. This is very close tail area. The osteoblastoma is a benign lesion. It has a nidus more than 1.5 centimeter. The aggressive osteoma is a larger lesion more than 4 centimeters. Histopathologically, there is a haphazard deposits and trabeculae of oven bone rimmed by the osteoblast in a richly vascular stoma. We can see the said it osteoblastoma. The aggressive osteoblastoma has a more wider and more irregular trabeculae bordered by epithelioid osteoblast. Mitosis are very common, but it differs from the malignant part by the absence of this atypical mitosis, less like osteoid, and permeation or invasion into the surrounding bone. So ALP, that is the atypical mitosis, less like osteoid, and permeation. These all are absent in aggressive osteoblastoma, making it non-malignant lesion. When it is present, though it looks more low grade, it would be an osteosarcoma, it will be a low grade or well differentiated osteosarcoma. Now, if a bone forming cells, you are seeing a malignant radiological features. Directly look into the lesion, whether the lesion is in the medullary cavity and it's showing a lytic sclerotic lesion, then it is a conventional medullary osteosarcoma. Here in the slide you see the sarcomatostoma, the malignant cells irregular. Anybody can see this is the malignant cells with less like osteoid. So less osteoid, less cell, bones, more cells. Now if we consider this as a sclerotic and the trabeculated lesion with a cortical destruction, they have a tumor with osteoid production. The cellularity is less compared to the conventional one, and there is a fibroblastic stoma, but still the cells are malignant. We consider this as a low grade osteosarcoma. If the malignant lesion with a expansional nature with atypical cells or malignant cells, then ABC like areas, then it may be telangiectatic osteosarcoma. The close differential with this is ABC, but ABC lacks the atypical cellularity. The cortical surface showing a bossylated radiodense mushroom-like mass lesion. This tumor has got a tumor osteoid, hypocellular atypical fibroblastic stroma. So the stromal component is increasing at that moment. It doesn't look like a malignant, but it behaves in a malignant way. This is parosteal osteosarcoma, though it's a low grade osteosarcoma. So here I am putting all these four, starting with this is low grade osteosarcoma. Here the cellularity is much more, mild degree of atypia, mitosis, atypical mitosis is very important in these cases of low grade osteosarcoma. This is a ABC where we can see that telangiectatic blood vessels. Now we can compare, that is this lesion also showing telangiectatic blood vessels, but look at the comparison of cellular atypia in these two. It definitely looks like malignant telangiectatic osteosarcoma. Here is the conventional osteosarcoma where we can see the less like osteoid along with the malignant osteoblast. Now after the osteoid, then we are going towards fibroosseous or histiocytic lesion or giant cell containing lesion. These lesions are mainly located into the metaphysis and diaphysial location with a ground glass appearance, and there may be Shepard-Crook deformity in these cases. Here we can see the regular and the natural bone formation is hampered. It is more of a combination of haphazardly producing bone in a fibroblastic soma. Here you can see the haphazardly arrangement of these bones, which is usually not seen in a good form mature lamellar bones. So this is irregular fibrous formation, and this is fibrous dysplasia. Now fibroosseous histiocytic lesion with a cortical metaphyseal lytic lesion and a fibroblastic stoma along with xanthoma-like cells, foamy macrophages and the giant cells in the certain category. Then in the benign counterpart we will getting a non-ossifying fibroma. Again the bone is not properly formed. Now, if the diaphyseal lytic lesion is there, there may be intense fibroblastic stoma along with the bone formation. We call this osteofibrous dysplasia. There may be adamantium showing nest of CK positive cells in the medullary cavity. Regarding the benign counterpart, there are lytic lesion with the epiphyseal location and having a soap bubble appearance, and there are sheets of mononuclear stromal cells with a fair number of osteoclastic giant cells distributed throughout the lesion. Now there may be expansile lytic multicystic lesion with a fibroblastic cartilaginous form there, and here the cells are forming short fascicles and has got a nature and details about the counterpart of the desmoid fibromatosis. Here it is a desmoplastic. Now comparing the fibrous nature of this lesion, this is, here you can see the abundant stromal component. Here you can see a large amount of stromal component, but the bromine tabaculi are irregularly arranged, are present. So this is a case of fibrous dysplasia. The giant cell tumor, here from the picture you can see a numerous giant cell, but the main pathognomic cells are these stromal cells, not the giant cells. Now in cases of NOF, this is also a giant cell containing lesion, but comparison to this, the stromal cells are more regular and more benign in nature in cases of NOF, but it is more cellular and more atypia cellularity in cases of giant cell tumors. Now adenoadenoma has got a typical epithelial islet. This is a desmoplastic fibroma or fibromatosis of the bone showing short fascicles with the capillaries compressed everywhere. Now this is about the fibroscortical defect and non-ossifying fibroma. We interchangeably use it. The non-ossifying fibroma is mainly significant for the older age groups with the larger vision, but the fibroscortical defect is morely seen confined to the cortex of the bone. In all these cases, they have got a characteristic storiform arrangement of the cells. Now these are the stromal cells and the giant cells. Stromal cells are less, but the giant cells are much more. There is a prominent cellular atypia. Now comes the fibrohistiocytic lesion, giant cell containing lesion with a malignant radiographic feature. There may be lytic lesions with the motile calcification and cortical destruction, giving rise to malignant spindle cell storiform pattern of giant cell tumors. And in other part, there is a poorly demarcated lytic lesion with a cortical destruction. These are these two. One is the MFH, another is the fibrosarcoma, showing the herringbone pattern, the characteristically seen in case of fibrosarcoma. Now after that, the bone and fibrous tissue, we are concentrating on the chondroid or the cartilage producing tumor. Here we have to look at where it is. If it is present as a surface cortical pedunculated mass, there is a periosseal fibrous rim followed by a hyaline cartilage. The ossification is endochondral ossification in this case. The epiphyseal lytic lesions are mostly of chondroblastoma, which shows a typical fried egg appearance in the histological slides. S100 positivity, here you can see the individual cell is embedded within the matrix. Now the medullary lesions, there may be well-defined lucent lesions with a benign hyaline cartilage surrounding. This is enchondroma, and there may be more cellularity in the cartilaginous counterpart with more cellular atypia, mitotic figures. Still fibrostoma is very less. This is of the fibrostoma is present in here. There is a cartilaginous element along with the fibrostoma. This is a case of chondromyxoid fibroma where you can see. Now this is the osteochondroma. Typically we see grossly. This is the exostosis, the cartilaginous part. This picture showing that beautiful cartilage above, followed by the hematopoietic bone marrow material. This is the morphology of the gross specimen. Now there is one entity like the previous bone forming one is the chondroblastoma. The chondroblastoma is a cartilage producing lesion, but it's a bit more aggressive. It shows some good amount of giant cells along with the cartilage, and bone formation may be there. This is the variety of cartilaginous lesion. This is enchondroma, where the cellularity is increased, more cells in the lacunae, but this is a tumorous proliferation, not a normal mature cartilage. So this is enchondroma. Followed by there is a chondromyxoid. Stomal background is very high in these lesions and very characteristic cartilaginous lesions along with the fibroblastic stoma. The most common is the chondromyxoid fibroma, and the lower two pictures are of the malignant cartilaginous counterpart or the chondrosarcoma. These are the large cells. You can take those large cells are very important. They may show cellular atypia, mitotic activity, and it is as the lesions goes from the benign to malignant area, the cellularity increases. Now comes the conduit producing tumors with malignant features. Here lies the lytic lesion with the cortical destruction, one of the signs of malignancy. That is the axial and the proximal skeleton most commonly affect. These are the low grade chondrosarcoma. Here you can see cellularity, but the cellularity is much less compared to the other classical chondrosarcoma. There may be clear cell pattern. Clear cells may be embedded in the chondroid matrix, and these cells are characteristically S100 positive. These are the clear cell chondrosarcoma. There may be glandular arrangement of the individual cells which are CK positive. So if any bone lesions with the CK positivity, it is more indicate towards a metastatic clear cell carcinoma, where you can see the clear cells. There may be combined lytic and the radiodense lesions. There is a variable sarcomatous pattern or chondroid differentiation among the cells. So one is the most importantly mesenchymal chondrosarcoma, and another is dedifferentiated chondrosarcoma, where it starts with a chondrosarcoma, then later it moves to a more malignant part. Here is the characteristic of mesenchymal chondrosarcoma, showing the typical small round cell along with the cartilaginous lobules. The clear cell carcinomas, the clear cell clear cell chondrosarcoma, again there is a malignant lesions with the cells showing the clearing of the cytoplasm. The dedifferentiated chondrosarcoma, it may transform into the other lesions, that is the spindle cells. There may be development of osteosarcoma or other chondrosarcoma in these cases. Again, the comparison with the different type of cartilaginous lesion. This is enchondroma, the chondrosarcoma. The cellularity gradually increases into the grade 3. This is again chondrosarcoma grade 2, showing a spindle cell appearance along with the increased mitotic figures. Now after that, this lies the small cell lesions of the bone. Now one of my teacher always says the small cell diagnosis, the initial diagnosis is not that difficult. When you see a black or deep violet side on your table, think of small cell lesions. If it is bone, it will be much easier. Sometimes there may be a multiple small type of cells. On the higher part of the microscope, you can appreciate there are reactive lymphocytes, plasmacytic infiltrate along with the neutrophil, classically seen in cases of chronic osteomyelitis, and which sometimes the surgeon misinterpret as a malignancy. Now then some of the cells show typical blastic cell infiltrate, that is a coarse nuclear chromatin, irregular nuclear margin, and with a plenty of tingible body macrophages giving a starry sky appearance. This is characteristic of Burkitt lymphoma. There may be polymorphous infiltrate with presence of Hodgkin's-like cells of classically seen in cases of Hodgkin lymphoma affecting the bones. And regarding the myeloma, there is a non-secretory myeloma which doesn't secrete the immunoglobulin, so there is an increase in the plasma cells and which show typical monoclonality or kappa or lambda restriction. Now these are the pictures of lymphoma pictures. So this is Ewing sarcoma. Here we can see a vacuolated clear cytoplasm. This is made of glycogen. Uh, and this is the metastatic small cell carcinoma showing the typical crushing artifacts like areas. At places nuclear palisading is noted. Now this is the plasma cell myeloma, or rather say plasma cell neoplasms, and this is the neuroblastoma showing the typical homarite rosettes. These things may be present in the bone as in the form of. Now coming to the small cells, with a production of different matrix, the small round cell tumor can be divided whether the matrix is present or not. If you see small round cells with a malignant stromal component or with some of the cells showing chondrocytic appearance, it is mesenchymal chondrosarcoma. Usually these lesions are S100 positive. Next comes the malignant tumor with osteoid production, that is osteosarcoma small cell variant. There may be metastatic small cell carcinoma, particularly in the kidney is one of the important area. Then comes the lymphoma, peanuts, and the Ewing sarcoma. Important thing is all look like almost same. So here the immunohistochemical markers are very important. For cases with a metastatic small cell carcinoma, we are getting CK, NAC, synaptochromogranin positivity. For the lymphoma group, we need the 45, 23 and the other markers. Regarding the other small cell lesions, CD99, MIK2, neural factor markers, these are also important. Now, there are some lesions which cannot be fit into some things. So there may be the hemangioma showing multiple dilated cystic cystic vascular channels containing blood material, characteristically seen in hemangioma. These are the slow growing lesion usually located in the medullary cavity. Next comes another important lesion is called chordoma. You cannot put it into the bone forming or cartilage forming lesions, but the chordoma is a very important thing. There are the lobular tumor composed of groups of cells separated by the fibrous septa. Now the cells have small round nuclei and abundant vacuolated cytoplasm, showing egg shaped bubble appearance, and there may be some large cells with the vacuolated cytoplasm. We call them as ficelliferous cell, which is characteristic of chordoma cases. So here, to conclude the everything, you have to have a systematic approach. So first see the age, demography and everything of the patients. Then you decide the location of the tumor as per the radiological findings. Then you observe the, with the information of this background information, you observe the slides and see whether it is producing bone or cartilage or other thing, or whether the slide is full of small round cells. Then as per category you put that thing inside. Then you compare again with the radiology and the histological findings, where the radiology will tell you about the whether the lesion is benign or malignant, and the histological cellular appearance, presence of different malignant osteoid, it consider the benignity or the malignant nature of the cells are determined. So hence I will continue my bone lectures. So first I started with the normal bone histology pathology, histological appearance and the bone basics. Now today I have given everybody a systematic approach on the different bone tumors. Thank you. More sessions of bone pathology will follow.